What we're doing this morning is introducing you to the State of Medical Education and Practice 2012. We published the first edition of this last year. And what we're trying to do really is to use and make interpretable to a very wide audience all the data that we hold, that we acquire as a result of doing what we do. We keep a register and we have fitness to practice proceedings, and we regulate education. As a result of doing all that, we collect loads of data. And traditionally, we kind of kept that to ourselves in-house. And over the last 2 or 3 years, Neil and I have been very keen to open up what we do and to pass the information on. So that's what we're doing. That's what's in the report. And with that very brief introduction, I'll pass on to Neil to talk about the report in more detail.
Okay, thank you very much indeed. Good morning. As Peter says, this is the second year that we've published this report. I suppose the obvious and first point to make is this is not a report about the GMC. It's about the profession we regulate. And I make that point because quite a lot of what we're going to talk about this morning is about complaints to the GMC, and it may look as if we're talking around the performance of the GMC and so on. But this report is about holding a mirror up to the profession and to the service on the basis of what we've learned and the data that we hold. There are a host of facts and figures in the report: a huge rise in the number of women in the profession, concerns about services that close down or reduce cover too much at night and at weekends, growing evidence of the link between educational support and the quality of clinical care, the need for doctors to be supported by their employers in raising concerns when doctors believe the care isn't good, and the fact that doctors face different challenges and risks at different points in their careers. Nevertheless, I think for us anyway, the most stark fact I think to emerge this year is the rising tide of complaints against doctors. Over the last 3 years, we've seen more complaints from patients and relatives and more from medical directors, other doctors, and others such as the police. The figures are all in the report, but in 2010 we saw a 24% increase. In 2011 we saw a 23% increase on top of that, and this year we're seeing at least that rate of increase again. Now, in one sense, this should be welcome. Where a doctor is putting patients at risk, it's right that we investigate and, if necessary, take action. But I think, and this is a really important point, more complaints does not necessarily mean worse care. Indeed, the evidence around a whole series of other things is actually about rising levels of satisfaction with medical care across the country. So what does it mean? I mean, the first point I think to make is we have a degree of humility about this. We have been trying to understand why this number is going up, and we have a whole series of reasons why it may be, but it is still in the maybe category and not in the definite. Let me just give you a few of those. First is better monitoring of medical practice. There's the system of medical directors in the health service has advanced significantly over the last few years, and the introduction of responsible officers under revalidation has taken that another step further, where the degree of responsibility understood and accepted by employers for the quality of medical practice within their organisations has increased very, very markedly. So better monitoring of practice may be a reason. Secondly, doctors are certainly more willing to speak out and less willing to tolerate poor behaviour than they were, say, a generation ago. And I think, again, this is a trend that's happened over time. Patient expectations, as I guess all of you know, are changing. Again, more willing to complain. And allied to this, I think, is the digital age in which more information is available for patients. In some cases, it may mean that local systems of complaints are not working, so people are coming to us to complain when, if they were working effectively, they could be dealt with at local level. Profile of the GMC's greater, so when there are high-profile cases, again, you tend to see after that more complaints coming to us. And ahead of revalidation, it may well be that responsible officers, medical directors are checking that all is well, are going through more systematically their doctors, and where they have some concerns, they are referring to us. So as I say, we don't fully understand how all these factors play, or what weight to place on them, but we're going to do that. We have, however, been responding. We're investing in more staff in our investigations and in our panels through the Medical Practitioner Tribunal Service. We've got a radical reform programme underway to our fitness to practice procedures, the way we present cases, piloting meetings with doctors and complainants. We'll shortly be introducing a helpline, confidential helpline for doctors wishing to raise concerns. And as some of you will know, we're also piloting induction for doctors who are new to the register, which we think will be of special value to those who are coming from overseas. The report provides for the first time evidence of how the likelihood of being complained about can vary depending on who the doctor is, the stage that they're at in their career, and where they work. So who you are, if you're a man, you're more likely to be complained about. Women, less so. The problems that women doctors tend to are more likely to come across are in terms of their health. If you're an older doctor, you're more likely to be complained about. In terms of overseas graduates, there's not a huge difference between them and doctors more generally. But if you're an older overseas graduate, you are more likely to be complained about, and the outcomes are more serious, affecting them. So again, where you are in your career affects the likelihood and nature of the complaint. So in the early years, you're likely to there are fewer complaints, you're less likely to have a complaint. There are more complaints in that area around probity and conduct when they're younger. Just after people get their specialist qualification or their GP qualification, usually the time when they're becoming a consultant or a fully fledged GP, as it were, on the specialist register, that you tend to see a rise in complaints around then. And again, don't know that we fully understand that. It may be about taking on new responsibilities. It may be, of course, they're more likely to be held responsible once they take on that role. And again, as I say, reflecting the older doctor point, towards the end of the career, you do see a rise in complaints. Where you work affects whether you're more or less likely to be complained about. The specialties where complaints per doctor are higher, around general practice, you do see very large numbers of patients, obviously. Surgeons, where perhaps the output is clear, and psychiatrists. And again, there may be reasons behind each of those specialties being more likely. The doctors working in smaller hospitals, the figures seem to show that they're more likely to be complained against, but the figures are too small and they're not statistically significant, but it is something we certainly want to look at some more. We know that patient outcomes are less good at evenings and weekends when there's less senior doctor cover, and from our figures there is evidence around when clinical supervision isn't satisfactory, you're likely to have more complaints to the GMC from that organisation. So finally, what's to be done about this? Well, obviously the purpose of the report is to stimulate debate and discussion. I have to say, overall, we think the state of medical education and practice is a cause for celebration. Our doctors are in demand overseas, and others want to work here. And overall, levels of satisfaction and trust in the medical profession remain extremely high. So concentrating on complaints, just want to make that a general point. But obviously there are also opportunities for improvement around the size and shape of the profession, understanding what's expected of doctors and what support they need. I think there's a big job for employers and for the profession itself. We will be publishing later this year our new core, a revised version of our new core guidance, Good Medical Practice, and want to engage with the profession and the service around embedding that and making it relevant for doctors in frontline clinical care. We'll also, for the first time, be producing good medical practice for patients, because we think it's very important that patients understand what's expected of their doctors, and indeed what's expected of them and how they can raise issues. On complaints, I think we need to understand better what leads to a complaint, what support doctors need, and more understanding, we're going to do some work on this, on which groups of patients complain and what they complain about. We need to look at tailoring support for doctors at different points in their career, support for older doctors, for example, and the work we're doing on induction for doctors at the start of their careers. And finally, I think understanding this organisational factors, what is it around organisations? We will, over time, I think, have a better understanding of what's happening at trust and board level in terms of our figures, issues such as the size of hospitals and whether that does make a difference, and if so, what should be done about it. So hopefully that gives you a flavour of the report. As I say, overall we think it is positive. It is a profession that is changing radically and is meeting new demands all the time. But we also believe that there's action which both the GMC can take, but also the profession and the service can take as well, to continue to drive up medical standards in this country.